All right, you're good.
All right. So, I know a lot of you guys just said you had ACLS, you had 12 leads, but I'll be honest with you, I think we do you guys a really big disservice. You know, back in 2008, when we first went ahead and introduced 12 leads to you guys, some of you guys that have been medics longer than that didn't know how to read 12 leads. You kind of just picked up things through CE, kind of self-taught, but there's a lot more to 12 leads than just recognizing ST segment elevation. It helps us understand our patients a lot better. Now, I'm going to be very honest with you up front. Is this going to change your treatment? Because I know that's the big question everybody always wants to know. And the answer is no. I felt pretty confident. I didn't wear my body armor in here today because I know that you guys are going to hate me by the time we're done. But it's taking a look at 12 leads in a little bit of a different manner, recognizing some of the other things. And also showing you guys what I'm teaching my students. Now, to be very honest with you, I'll spend 3 full days, almost 24 hours on teaching 12 leads alone. You guys are getting a quick 3-hour snapshot of some of the information about 12 leads. Well, that's what CE is supposed to be.
45 minutes too much.
Oh, you'll have fun today. So we're going to start off by reviewing the anatomy of the heart, kind of taking a look at the chambers, blood flow, coronary arteries. We'll take a look at electrical conduction. Where do we place the 12 leads? To be very honest with you, a lot of people don't put a 12 lead on correctly. Looking at the different areas of the heart that could be damaged, you may recognize that, yeah, the patient has ST segment elevation, we're good, but do you know where in the heart the injury is occurring? Do you know what coronary artery is occluded? And if so, what kind of things can you or can you not do for that patient? Okay? So that's what we're really going to look at as we go through today. Now, to start off with, our heart, obviously you know, kind of sits in the chest. The apex of the heart, or the top of the heart, sits more anterior, whereas the base of the heart sits more posterior. So it's not straight up and down like you see right here in the picture. It's tilted backwards a little bit more. We're going to talk about the different walls, chambers, and how the blood flows through the heart and the electrical conduction. Now, when you guys go ahead and you see ST segment elevation, or you think someone is having a STEMI, the myocardial wall is the wall that is being affected at that point in time. How much damage is done to the heart determines how quickly you guys start the medication and how quickly we get them to a cath lab. This muscle right here is a pretty special muscle. It can go ahead and continue. It's got its own electrical conduction system basically in it, and it never tires. The cells are constantly working away in the heart to go ahead and be able to push blood flow through the heart. So we have the 3 main walls, the epicardium, myocardium, and the endocardium. And here's a quiz question. The area that's affected is the myocardial area that could be damaged. So when we take a look at a heart, you've seen so many people go ahead and draw pictures of a heart. And they basically draw a big circle divided up into 4 pieces, kind of making it look like the atria is the same size as the ventricles. One thing that we do a pig lab with all the students, and when we pull this out, they take a look at the left and right atrium, and they're really just little leaflets that sit on top of the heart. Those walls of the heart are really very thin because they're not pushing blood flow really that far. They're just pushing it from the atrial area down into the ventricles. And so the walls of the heart are very thin. They don't need a whole lot of muscle at this point in time. They also go ahead and they take a look, and the right atrium here, very, very small. The walls, again, are very thin because it doesn't need a lot of muscle to push blood flow to the lungs. Where we do see a majority of the muscle of the heart is in our left ventricle, and you can see how thick that is there because the body is, or the heart is pushing the blood all the way through the body, and that sometimes takes a lot of effort to be able to do so. So, blood will enter the body from the inferior superior vena cava. It goes into that right atria, down through the tricuspid valve. From the tricuspid valve, it goes to the right ventricle to the pulmonary artery, the pulmonary valve, the pulmonary artery to the lungs. And then it comes back from via the way of the pulmonary vein to the left atria, through the bicuspid left ventricle, aortic valve, and then out through the body. What is the one artery in the heart that carries deoxygenated blood? The pulmonary artery, yes. And what is the one vein that carries oxygenated blood? Also the pulmonary. Remember, the definition of an artery is taking blood away from the heart. So blood enters, through the vena cava, or superior inferior vena cava, right ventricle, and goes to the lungs. So it's taking blood away from the heart, and it's going to the lungs so it can be reoxygenated. The definition of a vein is it's going back towards the heart, and here it's coming from the lung back to the left atria, and so it's carrying oxygenated blood. So those are the only two vessels that are opposite of what we normally figure out. So when we take a look at our heart here, we have three main coronary arteries. We have a right coronary artery, and we have the left coronary artery. Now the left coronary artery will break down into two different branches. One is the left anterior descending, and the other one is the circumflex. 85% of all people are what we call right coronary artery dominant, meaning that this right coronary artery that comes off the base of the aorta here will wrap around to the posterior wall of the heart. The other 15% are considered left dominant, meaning that the circumflex that wraps around the heart is feeding the posterior wall. Now, we really can't make the determination of what a person actually is unless they're in a cath lab and they're having some type of issues. But understanding where the occlusions may be occurring in one of these vessels is going to give you a general idea of what kind of arrhythmias the patient may be in, how the patient may present, and even our treatments for some of these patients. So we'll start with the right coronary artery here. As you can see, the right coronary artery comes back off of the base of the aorta, and this is our main marginal coronary artery. That's the one that feeds the inferior wall of the heart. Okay? And then if we look at, it wraps around, and this one is a right coronary dominant. It feeds mostly the posterior wall of the heart. Now, if you have a patient who may be bradycardic, we could have maybe assumed at that point in time that somewhere in the right coronary artery there is an occlusion, because the right coronary artery in 85% of all people feeds that inferior wall. And in 60% of all people, it feeds the SA node. Remember, that SA node is our main pacemaker of the heart. That's the one that's going to beat anywhere from 60 to 100 beats per minute, and it sets the pace. We see a P wave when we see the SA node go ahead and fire. But if we're bradycardic, if we're between 40 and 60 beats per minute, maybe that heart is not getting enough oxygen to that SA node. That SA node might be failing at that point in time, and the AV node has had to take over for it. In 85% of all people too, it could be that the posterior wall. We miss pre-hospital, and actually within the hospital too, we miss about 50% of all posterior wall MIs. You guys go ahead, you have a patient who has chest pain, and you're looking at them and you're thinking, okay, I'll put them on the 12 lead, and you see nothing. No ST segment elevation. You're like, oh, yeah, they must just be having something else going on. But we need to take a look at that back of the heart. We need to do maybe a 15 lead or adjust some of the leads to make the determination. Are they having an occlusion in the posterior wall of the heart? What am I actually seeing? Some of the other things the right coronary artery will feed, it feeds the posterior fascicle of the left bundle branch. Now, we'll get into a little bit of the conduction system, but there's two separate fascicles of the bundle branch. And this one will feed the posterior, which again, if you remember, the right side of the heart is our pulmonary side of our heart. With these patients, the posterior fascicle can indicate people having problems with breathing, emphysema, COPD, pulmonary emboli, which can lead to having some type of conduction or occlusion problem. Our left coronary artery, it does originate still at the base of the aorta where it attaches to the heart. However, it does divide into two separate. It divides into the anterior descending and the circumflex. So you'll see the left main come off here, and then here's the circumflex wraps around the back side of the heart where this main vessel comes down, and that's feeding the anterior wall of the heart. Now, our anterior wall of the heart travels along the right and left ventricle, and it feeds the anterior side. Does anybody remember what leads, if we see elevation, indicates an anterior wall MI? V3 and V4. So if you see elevation in V3 and V4, that means that your anterior descending, somewhere along in here, we have an occlusion. It also feeds the interventricular septal wall, so if you see elevation in V1 and V2, that looks at the septal wall. We can still be seeing an occlusion on that anterior descending. It feeds most of the right bundle branch and then the anterior fascicle of the left bundle branch, and only just a little bit of the posterior fascicle. Our circumflex, and again, depending if someone is right or left coronary artery dominant, the circumflex circles around the back side of the heart. In some people, does feed the posterior wall. In about 40%, it feeds the SA node to some people, and 10 to 15% in the AV node. Yes, this is just a smaller group of people for the left coronary artery circumflex vessel that they may be dominant. All right, so if we take a look at the electrical conduction through the heart, and this is just basically I'll review for you. The SA node is our natural pacemaker of the heart, has an intrinsic firing value between 60 and 100 beats per minute. From there, when we see the SA node go ahead and fire, we will start to see the P wave. When we see a P wave, we say it's a sinus rhythm. And then we know that it's originating from that SA node, the sinus node. From there, it goes to the intranodal pathways, down to the AV node. Now, the AV node has the intrinsic firing value of 40 to 60, meaning that if for some reason that SA node does not go ahead and take over as being the natural pacemaker of the heart, the AV node will sit there and it'll wait a little bit, and it'll kind of sit there and hang out until it realizes the SA node isn't going to fire, and it will pick up as far as the firing. But now the AV node is only going to beat 40 to 60 times per minute if the SA node isn't working. From that AV node, it goes through the bundle of His, and then it works its way down the bundle branches to the Purkinje fibers. You can see here, as far as the bundle branches, we've got our right bundle branch, but then our left goes into the anterior and posterior fascicles of the branch. So it kind of branches off a little bit. So when you guys run a 12 lead on somebody, and I'm not just talking about putting the monitor on and putting a 4 lead and just doing a quick rhythm check, but when you put the monitor on somebody, where do you put your limb leads? Do you put them right here and in the thoracic area? Most of you do, because that's what you've been taught to do for so long, right? Some of you put them where? Very good. They're limb leads for a reason, right? Yeah. If you are monitoring a 12 lead, fine. You can use the thoracic, but if you are using your 12 lead to identify a possible STEMI, or you are using your 12 lead in the diagnostic fashion, it has to be on the limb leads. Why? Because the computer in your monitor is set up to measure certain radiuses and axes based on a program when you guys go ahead and put these limb leads on. You will miss a great deal, almost 50% of all STEMIs, by putting them on the thoracic ear. Oh, that's kind of, this is the new way they're actually talking. I was just pulled a study that talked about putting them on the arms and then the mid-thighs, and they're saying that that's fine too, but to me, it's harder to get to those areas, and why not just use the end of the limbs? It works a little bit better, but you will pick up more STEMIs. Try it yourself. Next time you have someone who has a STEMI and you got a little bit of time going to the hospital, put them back on the thoracic area. See what you're missing, because you will see a change in your rhythm interpretation for these if you don't do it the correct way. So we also have what we call unipolar limb leads. These are ABR, ABL, and ABF. We do not use ABR. Our monitors are set up, like I said, it's a computer program, and based on where you put the leads, it does its measurements and accesses, and it comes up with an average, which is this black dot here in the middle, which is called our central terminal. And what that's looking at is it's looking from the central terminal to each one of these leads. So ABR looks from the central terminal in the middle up to the upper right shoulder, mainly looking at the right atrium. We as a pre-hospital providers do not identify anything with ABR at this point in time. They're starting to throw bits and pieces into it, but we haven't really grasped or gone forward with information on ABR yet. If you're looking at ABL, ABL looks at the lateral wall of the heart. This one will actually go from here down to the left lower leg, and it's looking at the side of the heart. ABF also looks down to that left lower leg, but this is more looking at the inferior wall of the heart. We look at it. So if you take a look here, your bipolar limb leads, which is your right arm, right leg, left arm, left leg, they all go and they measure right to that central midpoint, the central terminal here. And leads 1, 2, and 3, they all look at different areas of the heart. Lead 1 will look at the lateral side, because if you remember how the heart actually sits in the body, it's looking at the lateral. Lead 3 is looking at a part of the inferior. Lead 2 is also looking at part of the inferior wall of the heart. And then we have our precordial leads. These look at all the areas of the heart itself. A lot of people will say, well, you know what, I put it on a 2-lead. If you're looking at lead 2, you really don't have any idea of what's going on within the whole heart. You're getting just that one area. And lead 2 looks at the inferior wall of the heart. So you're looking at just one area. All right, take a look. What do you see? What do you see on Eric here?
Boredom?
No, I mean, you can see that side, but what do you see? Is Eric smiling, or what's he doing?
Yes.
You can't see, right? I know, right? But it's the same thing when you put on a 12 lead. When we look at Eric here, it's the same thing as looking at the heart. If you're not doing a 12 lead and using your precordial leads, you don't know what's happening in other areas of the heart. So, if you're just using lead 2 just looks at this inferior wall. If you suspect someone having a heart attack or they have chest pain and you're not seeing something in lead 2, you have to be doing a 12 lead. You have to be able to take a look at the whole entire heart, all the different walls. Okay, we have to see everything. And then the only way you're going to get that is with putting on the precordial leads or the 12 leads. Lead 2, you just look at one minor little spot. We're going to break down our EKG complex here. We started off with the P wave. If the SA node is firing, we will see our P wave go ahead and appear. That means atrial depolarization. The P wave should be upright, it should be rounded. The P wave alone should be 0.11 seconds long. And all the P waves there should look alike in all of your complexes. From there we got the PR interval, from the start of the P wave to the start of the R wave. That is the time it takes to go from the SA node down to the bundle of hits. Because remember, your AV node, that's your gatekeeper of the heart. It's going to hold on to that impulse a little bit longer because it needs time for the blood to go from the atria down to the ventricles to fill completely before it goes ahead and does ventricular depolarization. Now, just because you have ventricular depolarization does not mean you will necessarily have a contraction. It could be just strictly electrical. Our QRS complex, we talk about a QRS complex, but to be very honest with you, most people only have an RS complex. We'll break it down a little bit more in the next slide here when we talk about the Q wave and what the Q wave really indicates. Then, so our QRS complex indicates ventricular depolarization. We have the ST segment. This is actually the beginning of the repolarization, and this area should be at the isoelectric line. And then our T wave indicates ventricular repolarization. If you take a look at the P wave or T wave and you break it in half here, you're going to see what we call a refractory and an absolute refractory period, meaning that in a certain time, that area of the heart or the ventricles cannot be depolarized while they're repolarizing. If you're going to the relative refractory period, then it definitely can be. And we worry about that because if we're going to depolarize the ventricles at the same time they're repolarizing, the heart definitely at that point can end up going into VFib. It can get a little bit confused. So our P wave, as I said, is our SA node, virus, start of our sinus rhythm. PR interval, the electrical activity is going down through the AD node. Now, the Q wave is defined as the first negative deflection after the P wave. Not everybody has a Q wave. Generally, when we look at a Q wave, we think that someone has had an old MI. How many of you guys have heard that if I see ST segment depression, that means that they've had an old MI? For some reason, people were teaching that for the longest time, and that's not what it means. The signifying of an old MI is by the presence of a Q wave. Our QRS complex then is the ventricular depolarization, and the ST segment is the time it's taking for that the ventricle to repolarize. And then we have our T wave, which is the ventricles have completely repolarized. Most of the time, we do not see the U wave at the end here. The U wave is only seen in bradycardic rhythms, and they're not exactly sure what is going on with the U wave, but they've come up with the fact that it's probably the Purkinje fibers that are repolarizing at that point. Where we get really worried is when this QRS, we start to see a prolonged QT interval. This area gets longer and longer until it sometimes our QRS complex hits on our T wave and we have what we call RNT phenomenon, and a patient may go into VFib at that point. You guys have been taught mainly one thing with 12 leads. Recognize the ST segment elevation, because that's what you can do something with. You can give them aspirin, nitro, morphine, get them to a cath lab, and you've saved the day. But a lot of people don't realize, in order to make sure that we're recognizing ST segment elevation, we have to find that J point. The easiest way to explain it is at the end of the S wave where all of a sudden it makes a change in direction. If it is on the isoelectric line where it should be, everything's fine. If it's above, say up in this area, that's ST segment elevation. ST segment elevation indicates injury for our patients. If it's below the isoelectric line, it's considered ischemic. So we're getting ready to do a 12 lead on a patient. Obviously, you're not going to take it to some extremes like they do in the cath labs and the stress labs, but you want to make sure that the electrodes that you're using are good electrodes. They haven't dried out at all. Keeping them not on the end of the wires, you shouldn't be doing that because they have a chance to dry out. You want to make sure the chest is nice and dry, that you're getting a really good conduction in between the electrodes and your patient to begin with. If you have a male that has a lot of hair on the chest, you might want to consider shaving it or moving it into a little bit different area where there isn't as much hair. When we take a look at our 12 lead, one of the things we first of all teach students is the numbers that print off on the top. We tell them to look at those numbers. They're going to be able to identify the underlying rhythm just off those numbers without even looking at the 12 lead itself. Once they've figured out that, then they can go ahead and take a look at the numbers. The numbers don't lie. Our eyes can deceive us and make us see things that we don't necessarily see, or see different mimickers. Now, in a normal person, the electrical activity goes from that SA node down across our chest. It follows that natural electrical pathway, which is what looks at lead 2, which is why we look at lead 2, because it goes from this arm down to this area. But in some of our patients, the electrical activity doesn't necessarily follow that. It may come down to this area, and there may be some type of conduction problem, dead tissue, dead heart tissue, problem with the electrical pathway, and it'll send the electrical impulse to a different direction. And that's when we start talking about the different accesses of the heart. Now, with these 0 to 90 degrees, we consider to be a normal access. If a person's electrical activity comes down and ends up going to anyone in this 0 to 90 degrees, that's fairly normal for them. This is the chart that we use. Now, some people like to look at patterns and they'll say up, up, up is a normal access. Other people like to look at numbers. If you're looking at 0 to 90, that equals a normal access. We should see that on almost every one of our patients. If we see a 0 to negative 40, electrical activity comes down and bumps up into here, that is what we call a pathological left access. That's fairly common for most people. We don't get too upset about it. They're usually asymptomatic. It's not generally any type of issues. But if we end up with a patient who ends up with a negative 40 to negative 90, that's our pathological left axis deviation. This can be a number of things. It can be someone who is obese, pregnant, someone who is having respiratory, someone with a high diaphragm. It could be someone with a bundle branch problem, left bundle branch problem. It could be someone with coronary artery disease. But these people that have the pathological left access, they have a very high likely of going into cardiac arrest. And understanding with these patients that you might actually see them deteriorate very quickly. If you have the right access, 90 to 180, so it comes down and it shoots off to this direction. Again, the right side of the heart is our right, or is our pulmonary side. COPD, emphysema, cor pulmonale. So our right side, cor pulmonale, or right ventricular hypertrophy, pulmonary emboli. Those are types of things that if the electrical activity comes down and goes off into this direction, we might have some type of respiratory ailment. Now, children, it's very common for children to have right axis deviation. And then our last one is extreme right axis deviation, meaning that, they have anything greater than 180 degrees we call extreme right axis. This means it's ventricular in nature. You can pretty much say this patient is in VTAC just by looking at some simple numbers. Because the electrical activity is going, it's originating down here in the ventricles and it's going up to this direction. So here are some of the, I put some of the numbers that people will see on top of their 12 leads. And I know a lot of people are like, oh, what does these numbers mean? Doesn't tell me anything, but these numbers are numbers that are measurements. They're not going to lie. So if we take a look at this first one, it says our heart rate is 65 beats per minute. It's between 60 and 100, so I know it is a normal rhythm. Next thing I look at, I'm going to look at my PR interval. Okay, I know it's kind of blurry there, but PR interval should be between 0.12 and 0.20 seconds. This is that, can't quite see it here. I can't see that one, let's go here. This is a 0.15, so we know at that point we have a normal sinus rhythm. My impulse is originating in the SA node, and it's in between that time frame. We've got a good PR interval, everything's going fine. So I've got an underlying rhythm of a normal sinus rhythm. The next one I can look at is my QRS, 0.096. This should be between 0.08 and 0.12. That means my QRS complex is nice and narrow. It's not originating in the ventricles. But when we start looking at these axes here, we're looking at the QRS axis, which is normally the middle number on our patients. So at this one here, 72 degrees, that's between 0 and 90. This is a normal axis. This one here is a negative 24. Physiological left axis. This one's 114. That's extreme, or a right axis. So you can pretty much understand what might be going on with these patients just by what the axis is showing. So we have two main fascicles, or two main, well, three actually, three fascicles of our bundle branch system. We've got our right bundle branch, and then we've got our left bundle branch. And our left bundle branch is divided into the posterior and the anterior fascicles. Okay, it's going to do different areas. And if we go back and we take a look here, and we look at our different axes, a pathological left could indicate that this person has an anterior hemiblock. That's more that this patient is likely to go ahead and could go into cardiac arrest. Anterior hemiblock is not as bad as a posterior hemiblock if we see the axis between 0 and, or 90 and 180 degrees. But if we see the right axis, again, we're looking at something ventricle. These patients might have some type of right heart problems that we need to take a look for. Now, one of the things that you need to be very cautious on when you're dealing with patients who have right axis deviation or posterior wall hemiblocks, medications such as amiodarone that you give or morphine can slow the conduction through that AV node into the ventricles, causing a drug-induced heart block. And so we need to make sure that even when we're giving morphine to the chest pain patient, what might the implications of some of the different types, like if they have that anterior hemiblock, it might slow so much you might induce a heart block of some type. Let's go back here to our bundle branches. People live with right bundle branches all the time. Generally, no issues. They're really asymptomatic for the most part. But it's the left bundle branches that we have to be concerned about, especially a new onset. If a patient has a new onset of a left bundle branch block, you cannot go ahead and make the determination that they have a STEMI. So it's best to say that if a patient has a left bundle branch and you see ST segment elevation, you cannot call it a STEMI. You have to send them to the cath lab for that. It's, you know, when you're calling in, instead of saying, well, they've got ST elevation in these leads, just say they have a left bundle branch block, because then they know that they're going to have to go to the cath lab. One other thing, when we looked at these numbers here on our QRS complex, I told you should be between 0.04 and 0.12, or 40 milliseconds to 120 milliseconds. Anytime we take a look at this QRS number and it is greater than 0.12 or 120 milliseconds, that patient has a bundle branch block of some type. So I'm going to go back over here. So if we take a look at this first one here, we have a ventricular rate of 95. Okay, it's in that normal range. PR interval is 186 milliseconds, so it's between the 120 to 200. So the underlying rhythm of this patient is a normal sinus rhythm. But I look at this, Q restoration, 140 milliseconds. That's too long. It's taking too long for the electrical activity to make its way through the ventricles. So just by looking at this and seeing this greater than 120, this person has a bundle branch block. Now it's up to us to make the determination, is it right or left? Easiest way to determine a bundle branch block after you see that this is greater than 120 is to look at V1, lead V1. If I'm driving a car and I want to use my blinker and I want to make a right-hand turn, I push my blinker up. If I see a positive R wave in V1, I have a right bundle branch block. If I am driving my car and I want to make a left-hand turn, I push my blinker down. If I have greater than 120 milliseconds here and a negative deflection in V1, I have a left bundle branch block. Okay? Let's go back to this right one here for just a second. I can go on to say I have 91 access. That's pretty normal. So this patient has a right bundle branch block. I could probably say that they may have some respiratory issues. They're pretty asymptomatic other than that, but overall this patient should be pretty stable. We take a look at this, we look at this and we go, oh, this one really looks bad. This patient's got to be dying on me, right? But ventricular rate 76. PR interval is 230. That is too long. My next step should be to take a look, go down to lead 2. Do all of my P waves look alike, or are they about the same distance apart? And if they are, I can say my underlying rhythm is a first-degree heart block here, because my PR interval is greater than 0.20 or greater than 200 milliseconds. Next thing, my Q restoration is 170. That's above 120. So I go over to V1, I have a negative deflection. This is a left bundle branch block. Now, what can I tell you about this patient? I can tell you this patient is probably hemodynamically unstable. People who have Q restorations that are greater than 170 milliseconds will generally be hypotensive. Okay? He's got a pathological left axis deviation. It's not uncommon that we would see this patient go ahead and maybe code. We look at this and we say, oh, there's elevation here, there's elevation here, here, and everywhere. But we can't call this a STEMI. We can't call this a STEMI because this is a left bundle branch. And left bundle branches, because of the widening of the QRS complex, mimic elevation. The only thing we can tell the hospital when we see this is, my patient has a left bundle branch block, they're hypotensive, they're going to need to go to, we don't say that, but they're going to ultimately need to go to the cath lab with this patient. Also,
are we then not supposed to say we're bringing a possible STEMI then at that point?
if it's a left bundle branch, it's not a possible, well, we don't know. They're going to have to go to the cath lab regardless.
Right,
I would
but
call
my
it
point
cardiac
is that
alert.
when we call in saying we've got an ST, if we call in saying we've got a STEMI, that's supposed to be putting the hospital on notice to get a move on, right?
Right, but this more than likely is not a STEMI. It's more of a STEMI mimicker. I would say I've got a patient with a left bundle branch block, and that's going to be a little bit more accurate to go ahead and say than someone who has a STEMI for these patients. Patient with a left bundle branch block is not as immediate as someone who is having a STEMI. So take a look here. We have a ventricular rate of 70. PR interval 136 milliseconds. So we've got a normal sinus rhythm. Q restoration is 156. So I take a look at V1, I have a negative deflection. This is a left bundle branch block. Now a lot of people when they run it, they'll say, oh look, I've got these rabbit ears. Rabbit ears do not always mean a patient is in a bundle branch block. You cannot define or diagnose a bundle branch block without a 12 lead. You must have a 12 lead in order to diagnose a bundle branch block. Okay? And also the rabbit ears are telling you, some people will say, well, if the right one's higher, the left one's higher, it's the right, it's the left. I'll be honest with you, I get very confused when they start talking like that. I just go as simple as can be. I look at my numbers, which way does V1 point, and that usually is, well, that is the right way to go ahead and make the determination. Now, this has also got a normal access. This patient, is probably not super hypotensive based on the Q restoration. Probably experiencing chest pain, lightheadedness, dizziness. This one is probably a conduction problem more so than a STEMI. There's other criteria out there that we can go ahead and start teaching, such as Sheboygan's criteria, which is a lot of mathematics and numbers that we're not going to do pre-hospital. To make the determination, we'll let the hospitals go ahead and finish that. But more than likely, with a lot of these with left bundle branches, it's going to be a conduction problem that we're seeing with them. All right, so heart rate's 81 beats per minute. PR intervals less than 0.20 or 200 milliseconds. Q restorations greater than 120 at 130. I look at V1. Positive deflection. This is a right bundle branch. This patient here is probably asymptomatic, but not feeling good, lightheaded, dizziness, and this patient also has a normal access. But it doesn't mean to say that people look at this and say, oh, this looks like elevation here. That's not elevation, that's actually an RR prime. There's so many things that when we look at them, and the big reason to bring a lot of this to your attention is because you guys will call us and say, you know what, we called a STEMI, we saw elevation, they didn't believe us. But a lot of the STEMIs that you guys are seeing, or the elevations, it could be one of the STEMI mimickers, which we're going to talk about here in a little bit. And it's hard to recognize those unless you fully understand what a 12 lead is telling you. So when we look at this, ultimately we're trying to get them so we can get this occlusion over them, get them to a cath lab. Door to balloon is 90 minutes. And they are starting to look at you guys as part of that 90 minutes. When did you meet that patient? When did you first come to patient contact? When did the balloon go up? Was that within 90 minutes? 12 leads should be being done bedside. 12 leads should be done before you go ahead and you give any nitro. You guys can make the change in a 12 lead if you're giving nitro before you take it. You're opening those coronary arteries, and that's the whole purpose of the nitro, is to dilate the coronary arteries, get more blood flow to these areas, and that can actually cause the ST segment elevation to go ahead and return to a normal baseline. What you guys have been taught in the past is look for the elevation. Now, ST segment depression, okay? As I said before, a lot of people were taught, oh, I see this ST segment depression. This guy's had an old heart attack. That does not mean that. ST segment depression means ischemia, means that heart needs oxygen in that area of that wall of the heart where this lead is looking. If we go ahead and give them aspirin and nitro and morphine and dilate those coronary arteries a little bit, this ST segment depression can go back to baseline. The other thing is T-wave inversion. T-wave inversion can also indicate ischemia, means the heart's irritated, it's not happy right now, but you can do something about it. Now, when you guys do your 12 leads, are you putting in, is it a male or a female in the proper age? Absolutely. Remember, it's a computer, and parameters that you put in are that printout that comes out a lot of times is wrong unless you're putting good information in. ST segment depression here on a 27-year-old male is perfectly normal, not a big deal. But T-wave inversion on a 57-year-old male, that is an issue. Okay. Then we're looking at ST segment elevation. ST segment elevation means injury, means we've got to do something right now to get this heart perfusing or it is going to die. The muscle itself is going to start to die. Again, aspirin, nitro, morphine, getting them to a cath lab as soon as possible can go ahead and help save some of that. Right now it's just injured, but we can fix injury. Where we can't fix is when we start to see the Q wave. And the Q wave is a pathological Q wave, meaning that the depth of this Q wave is 1/3 the whole distance of the R wave. If we see that long Q wave, that means the heart's infarcted. The tissue's dead. Nothing you're going to do is going to fix it. But the good thing for you guys when you see something like this is you can stop the depth from expanding in this heart. You guys can go ahead, get them the aspirin, the nitro, get them to the cath lab, and limit the amount of heart damage that they actually may have at that point. I'm sure this isn't the first time you've seen this, but we take a look at all the different leads and what walls of the heart. We know that if we look at 2, 3, and AVF, that looks at the inferior wall. Leads 1, AVL, V5, and V6 look at the lateral side. V1 and V2, septal, V3 and V4 is our anterior side. So we can kind of have an idea where that heart attack is looking. If we want to go one step further, we can say that leads 2, 3, and AVF, if we see elevation, that is affecting the right coronary artery. Lead 1 in AVL, and somewhat times V5 and V6, that is my left coronary artery. 1 in AVL specifically are circumflex. V3 and V4 are anterior descending, and V1 and V2 is also our anterior descending. Now when we look at our 12 leads and we see elevation on one side, we should on the other side of the heart see ST segment depression. And we call that reciprocal changes. So if we take a look here and we see elevation in 2, 3, and AVF, leads 1 in AVL, we should see ST segment depression. Because remember, when electricity flows towards one area of the heart, it's going to cause elevation. When it flows away from the area of the heart, it'll cause depression. So if you're talking about the opposite side of the heart, you're going to go ahead and see. Now, one thing we've asked you guys to go ahead and do when we take a look at the area of the heart, if you see elevation on the inferior wall, leads 2, 3, and AVF, we've asked you to go ahead and do a right side and 12 lead. What we're looking for is to say, is this really an inferior wall MI, or is this a right ventricular MI? What do we have associated here? So if I take V4 off of the left chest and put it on the right chest, run my 12 lead again, and if I see elevation, I can tell you right then, I have a right ventricular MI. I probably have hypotension, I've got JVD, I've got clear breath sounds. These are the patients that definitely we don't want to give nitro and morphine to. But if it's strictly just an inferior wall MI, we run and we take V4 over here on the left side, we put it on the right side. Why can't we give aspirin or nitro and morphine? There is no reason. We stopped giving, the reason we were doing 12 leads before you gave nitro is so we could see where it would be appropriate to administer meds and where it would not. You guys are smart enough to be able to figure out that, yeah, it's inferior, we're fine to give aspirin and nitro and morphine. Oh, if it's right ventricular, no go. We need to give fluids first, and then we can go ahead and give them their nitro. And when we write our protocols, to be very honest with you, we write it to the stupidest person, the stupidest medic in the whole entire system. Because we've got great medics who really would understand this and know how to treat a patient. And then we've got medics who don't care and they're not even going to be able to figure this out, and they're going to kill somebody if we give them the opportunity to think about it. So we just don't let them on the ambulance, that's all. So So then when you look here to our right coronary artery, and on the back side, here's that posterior wall. That's the patient that you don't want to give aspirin, or you don't want to give nitro and morphine to, because the right ventricle is very dependent on preload. We should be given 1,000 cc's of fluid first, and then after we raise the pressure back up, then give the aspirin or the nitro and the morphine for these patients. Here we have the anterior descending, and you can see this is V1, V2, V3, V4. That's going to cover that anterior wall and the septal wall of the heart. And then our lateral wall is here, V5 and V6, or 1 in AVL. Understanding what coronary arteries are associated with it. So, everybody reads 12 leads a little bit different. Some people like to read them across all the way. Some people like to read them up and down in columns. It really, whatever works for you. But we take a look at V1, or lead 1 here. We look like we have some depression. Lead 2, we have elevation. Lead 3, we have elevation. AVL, we have depression. AVF, we have elevation. Inverted T wave in V1.
There's going to be a signal.
Okay, V2, T wave inversion, V3 is fine, V4 is fine, V5, V6 are all good. So we have elevation in 2, 3, and AVF. What wall is that? Inferior, and what coronary artery? That would be our right coronary artery. Again, as I said, if you look on the opposite side of 2, 3, and AVF is 1 AVL. And here we have ST segment depression. We have reciprocal changes. This patient, we normally would not give aspirin, or we would give them aspirin, but not nitro, not morphine, unless we call medical control and talk to them. It can make the difference if someone is absolute hypotensive or relative hypotensive. Absolute hypotension means that the person's blood pressure is less than 90 systolic. Relative hypotension, meaning that normally their systolic is 150, but today their blood pressure is 110. And we look and we say, oh, they got 110, we can give nitro to these patients. But because of a change in greater than 20 points, this would cause their pressures to probably drop even more. Yeah, so overall, this patient, we would just normally go ahead and give aspirin and transport. It would not be wrong of you to start giving them fluid boluses, increase the preload on these patients because the right ventricle is what's suffering. It wouldn't be uncommon to see JVD on this patient. All right, take a look here. Lead 1, we see elevation. 2 is fine. 3, we have an inverted T wave. AVL is elevated. AVF is fine. V1 is fine. V2 elevated, V3, V4, V5, V6. All of those elevated. So, Remember, you have to have 2 or more contiguous leads for that wall to be affected. If we look at V1 and V2, only one of them has elevation. So the septal wall at this point in time is not involved. But 1, ABL, V5 and V6, that's our lateral wall. V3 and V4 are anterior. So you could say this person was having an anterior lateral wall MI. And right here you can see we have Q waves, and these Q waves, at least in these leads here, are greater than 1/3 the distance of the whole R wave. So instead of just being injured, we've got dead heart tissue. But depending on how quickly you guys act, you can make the difference in between, is it going to be a great deal of heart tissue damage or very little heart tissue damage. That's why we got to tell you guys, who do we run 12 leads on? All of our anginal equivalents. Anybody over the age of 40 who complains of not feeling good, lightheadedness, dizziness, weakness, something's just not right, gets a 12 lead. Diabetics who complain of, I don't feel very good, whether they're 20 years old or they're 100 years old. Our elderly patients, if they say, oh, I don't feel quite right, I'm tired, I've been exhausted. All of these are anginal equivalents, and we need to run 12 leads on them. And the sooner you do them, they should be done bedside, the sooner you can get nitro on board, the sooner you're going to get oxygen to areas of the heart that are injured or irritated at that point. All right, we take a look at this one. Lead 1 looks good, lead 2 looks good, lead 3 we have an inverted T, ABL's fine, ABF's fine. But here we have elevation in V1, V2, V3, V4 is fine, V5 is fine, and V6 is really fine. This is just a septal wall. We've got, and it's not a Q wave, so it's injury. V1 and V2 are both elevated. V3 is elevated, but V4 isn't. So again, 2 or more contiguous leads. So we want to make sure that this is just be a septal wall.
21, they call it section of the way to the fire.
All right, if we take a look at this one, lead 1 is elevated, 2 is fine, 3 is got depression, ABL has elevation, ABF has got depression, V1 is good, V2 is elevated, V3, V4, V5, and V6 are all elevated. Again, we have some reciprocal changes in the inferior from our lateral wall. V1 is fine, so it's not septal, so this is an anterior lateral wall infarct. We've got our Q waves that are greater than 1/3. We've got some pathological Q waves going on here. Not that we want to add anything else onto what you guys do in the field, but we've been talking about moving V4 to V4R. That's been standard. Anytime you see elevation in 2, 3, and ABF, you should be moving V4R. There are times that it would be indicated to do a 15 lead on a patient. Now, we're not using all 15 leads. You'd be moving a total of just 3 leads for these patients. But if you have someone who has chest pain but ends up with a normal 12 lead, rule out that they're not having a posterior wall MI. You have someone who has an inferior infarct. Move it to see, is it right ventricular or is it just inferior? Or the other one is that I have V1 through V4, I have ST segment depression. If we have depression on one side of the heart, which would be our anterior side, then we may have elevation on the posterior side. Again, that might be some type of indication. So how do we do this? Well, we start off by taking V4 here and we move it to V4R. We're not having you move V1 and V2 or V3. You can leave those alone. The only one we're looking for you to move is V4. That will tell you if it's a right ventricular MI or if it's just an inferior wall MI. If you want to make the determination you have depression in V1 through V4, and you want to rule out a posterior wall MI, you're going to move V5 and V6. And what you're going to do is take V5 and V6